Good afternoon, everyone. Hope there will be more filing in. Many of you may recall Heather Bergeson. Heather Bergeson was a resident and chief resident here. She went to medical school at the University of Kansas, was resident and chief resident here through 2013? Or 2003. Yeah, 2013. You'd love that. Yeah. She was was at Wayzata Children's for a number of years, went back, did her sports medicine fellowship, and has been at TRIA. She is an adjunct professor of orthopedics here, has a great interest in sports medicine and kids and the culture around sports medicine, or sports for kids. She also is I'm going to make a plug for something I put outside or on the back table. She is the medical honoree this week for the Arthritis Foundation's Walk to Cure Juvenile Arthritis. She's on the board of directors for the Arthritis Foundation, has been a great contributor there. She's also one of the top 4 fundraisers this year for the Arthritis Foundation. So she's going to get a special treat for a team tailgate this Saturday at the walk. You can contribute to her team and get her to number 1, or you can contribute to the university's team if you'd like. That's what the handout is in the back. Heather, thanks for coming to speak. It's a pleasure to have you here.
Thank you. It's a pleasure to be here. Do I need backup? Or no? I'm up here? Okay, good. So thanks for having me. It's good to be back here, although I never got to be actually here in this space, which it's amazing over here. And sorry I was late. I got kind of lost through here. That was not the right one. So no disclosures. What we'll do today is talk about apophyseal injuries in kids and what causes them and how the crazy youth sports culture contributes to the increased frequency with them, and talk about how to manage them and, most importantly, how to prevent them. So kids are different, right? Growing bones are different because they've got growth plates, those areas on the long bones that are responsible for the longitudinal growth of the bone, but because they're open areas on the bone, they're weak links. But they also have apophyses. So like in the elbow here, here's the growth plates through there, but the elbow, as you know, is very bizarre and it has all these apophyses. So they're not responsible for growing the bone long, but it's where tendons attach. But because it's an open area, it's a weak link and therefore more prone to injury. And then these kids have this rapid growth spurt, right? So they're more awkward and gangly, more prone to injury. And then you may have a size mismatch. So you've got this guy going up that guy, and that's probably a recipe for injury at sometimes too, right? And then they have just still underdeveloped muscles. Their core strength hasn't caught up yet. They're still developing their fine motor skills. And then on top of all that, they're dealing with all of the pressures from parents, from coaches, from their peers, oftentimes from themselves. It's a lot to manage. I'm not sure I'd want to be a young athlete these days. But there are so many benefits of sport, and that is why we want to keep these athletes in their sport. So apophyses. Like I said, they're secondary ossification centers, sites where tendons attach onto bones. And we've got them all over our body, anywhere tendons attach onto the bones. In the pelvis, there's a ton of them. So it's an area where we see a lot of apophyseal injuries. And what ends up happening is with overuse, the muscle tendon pulls on that apophysis. And because it's an open area, it's a weak link. And then it gets irritated, inflamed. And sometimes you can actually pull it off and get an avulsion fracture there. So parents always ask me, why did this happen? All these other kids are playing just as much as my kid. Why is it happening? And I always say it's multifactorial. Part of the problem is genetics, and you have to choose your parents wisely. Sometimes that's easier, Jordan. A lot of it is just that puberty, that growth spurt. The bones are growing longer. Their muscles and tendons are hanging on for dear life, and there's that mismatch and imbalance. And biomechanics. A lot of times they're not engaging their core muscles like they should. Things are out of balance, and it makes them more prone to overusing a certain muscle. But most of it is overuse. So what is overuse? It's any excessive repetitive use of a muscle, tendon, bone without adequate time to heal that then causes injury there. And I love this quote, no pain, no gain. I'd like to punch the guy who said that. So Frank Jobe, I would too. Frank Jobe is was a famous surgeon. He's the first surgeon to do the Tommy John ligament repair in pitchers, right? So that ulnar collateral ligament that ruptures. So he had a lot to say about youth overuse injuries in sports. So why do we worry about it? Well, the good news is that there's lots of children playing sports, and probably over 40 million children play organized sports every year. There's 3.5 million injuries every year. Half of those are overuse injuries, which means that we can prevent half of these injuries from happening and prevent things like this where you get an avulsion fracture and need a surgery to go in and fix that. So unfortunately, sometimes the game they love doesn't love them back, and these kids are getting adult-type surgeries just because they're playing too much. Now, this is a great website, stopsportsinjuries.com, and it's a joint collaboration, AAP. If you guys have seen this before, they have really fantastic resources for coaches, parents, athletes on sport-specific things, injury-specific, body part-specific injuries. So it's a great resource, and we're a contributing sponsor for that program. So then, why are overuse injuries on the rise? A lot of risk factors. You guys have heard about this before, but the whole problem with early sports specialization and year-round play, which is definitely a problem. But one of the things I see more of are these kids who have a year-round sport, but they're playing 3 other sports at the same time. So they're going from hockey to lacrosse to soccer to baseball. They're playing 3 to 5 hours a day sometimes, and that is more worrisome to me than actually just playing one sport. But it's that focus on one sport, you're using the same muscles all the time, and makes them more prone to injury. And as we said before, their growing bodies are more susceptible to injury. They're not getting enough rest periods. These kids are way overscheduled. A lot of times they come in just unconditioned. So they start off the cross-country season, and they're expected to be ramped up, and they're not, and they just aren't ready to do the mileage and get injured that way. Sometimes the equipment or surfaces that they're playing on, the turf, things like that can play a role. And the biggest thing probably is our unrealistic expectations on these kids is we're training them like little professionals. And their bodies aren't meant to do that. So it's this competitive youth sports culture that is the problem. And I could talk for a long time about this. And Rich told me that I could get up on a soapbox today, so I'm going to do that a little bit. So I get this. So my kids play hockey. And when my son was in 2nd grade, we get this handout or this, mailer that had this on here for Mite Hockey. So that's 2nd and 3rd grade hockey. And then remember, when you are not practicing, somewhere someone is, and when you meet him, he will win. Like, what are we trying to market here, right? And the truth is, that's true. Because all these other kids are practicing year-round, and if you don't practice, you're not going to keep up. You're not going to make the team you want. You're not going to be with your friends. Then maybe it isn't as fun anymore. So we have developed this problem that's hard to get out of. And then we put kids on the cover of Sports Illustrated, right? So this was not real. This was my daughter that they've had made for the door for her tournament. But there are kids that we put on Sports Illustrated and inflate it that way. But the good thing is that there's so many good things about sport, right? There's so many life lessons. There's so many moments. And as a parent, you see your kid have this just incredible moment, and you're so excited for them. They are pumped up. You want to keep them playing. You want to keep them out there. So how do we do that in this now culture that we have created? And with full disclosure, I have 2 kids that play hockey year-round, and we have built a hockey room in our basement. So I'm not sure that I'm exactly the best person to talk about it, but nonetheless, they have fun with it. So what's wrong with playing year-round? Well, we know they're more prone to overuse injuries, burnout. Majority of kids quit playing sports by the age of 13. There's a lot of factors to that, but a big one is because they burn out. And then it isolates them. They're not, maybe your kid was meant to be the best fencer in the state, but you decided they're going to play hockey, and that's all they're playing, and they just don't meet their full potential. They're not able to go and try all of the other sports that are out there. So those lost opportunities, I think that a lot of times they get manipulated into playing. Sometimes it's really hard to know what kind of kid you have, though. And when they're younger, they're complaining about going and doing the work or going to practice or putting on the gear or whatever. And it's very hard to know how much to push and how much to hold back. You know your kid the best as a parent, and so you have to figure that out. But there's a concern about compromised growth. Gymnasts, you always hear about that. I don't worry about that so much. What I worry about is if it's a gymnast that, let's say, has a a gymnast wrist and they've injured the growth plate there, then there gets to be some discrepant growth with the ulna and they get more problems and maybe have to have a surgery to fix that. So there can be problems. But the reality is that it's expensive too. I mean, having these kids play year-round, play on traveling teams, you're traveling to Kansas City and St. Louis and Florida and Cooperstown, wherever you're going for all of these tournaments, it's a lot. So Joel Brenner is the president of the Council on Sports Medicine and Fitness for the AAP, and in their statement paper about this, they really do find that those athletes who play in a variety of sports have fewer injuries and they play longer. So they're getting the benefits of sport for longer. So why do we let our kids specialize? What makes us do it? Sometimes it's child-driven. Sometimes they love it and they want to play and it's self-motivated. And, I mean, it's great to see them smiling and winning and succeeding, but it has to be self-directed. It has to be the child that wants to do it, right? And then there's always the talk about those parents that want their child to play pro or at least college. And, you know, the reality is most people realize now that is not going to happen. But even now, you know, my husband says, I just want my kids to have the experience to play at the varsity level in high school. Edina hockey, you think that's going to happen? No way. I mean, not even that's going to happen. So there's all of those things that go into it. And we want them to develop their skills and get better competition. So maybe they're playing on a house or rec league and your kid is really good and they're not getting the competition and you want to up that, so you start them up on a traveling team. And what is true, though, is the better they get, the more fun they have. But the main thing is that it's because everybody else is doing it. And if you don't do it, you don't keep up, and then then you fall behind and then they don't have the opportunity. And that's what we have to figure out how to get out of, is that cycle. And then we've had these inspiring examples, right? I had this poster on my wall when I was growing up, Andre, with the hair. But these are not typical. If you look at most pro sports athletes, they played a variety of things growing up. They did not specialize from an early age, and that's probably what kept them more successful. In the long run, it's all about the money. And our children are customers, not athletes. And even the people that say that they're there to develop your kid's skill, they're making money. It's their job. That's what they're doing. And so unfortunately, it's not about them having fun, and it's about the adults making money. Mark Hyman is an author who's written several books, so if you haven't read them, check them out. The Most Expensive Game in Town is a really good one. He was here a couple years ago now speaking, and does some other engagements around the country. So if you ever have a chance to see him, he gives a good talk. Okay, so that was a little bit of my soapbox. Now let's get more into the apophyseal injuries. And so what we'll do is start top to bottom, because that's actually how you start to see them. The heel starts when they're younger, and then it starts to move up the body as they get older. So Seaver's disease, you've all heard about this. One of the most common things that you're going to see is an overuse injury in kids. Usually starts around age 9 in girls, 10, 11 in boys. Girls are always going to be a little bit earlier. The books will tell you that all of these injuries, it's more common in boys. I would say we're starting to see it pretty even now that more girls are playing. They'll complain of pain just with activity when they've been running around. It gets better with rest. They localize it right to that apophysis on the heel. You don't need imaging. This is just a clinical diagnosis. However, there are some times, especially now with as much kids are playing, that I worry about a stress fracture in either the calcaneus or the talus. So when you're palpating, if they're tender right along here, you can be pretty sure that that's just an apophysitis, calcaneal apophysitis, or Seaver's disease. But if you get a little bit more interior and they're tendered here or up in the talus, then and they're really active and they are playing a lot of sports, make sure you're not dealing with a stress fracture. And in those cases, I do get x-rays. A lot of times you're not going to see it. And sometimes I'll get further imaging with an MRI to see, am I seeing some bone marrow edema, and do I need to put them in a boot and shut things down? For the most part, kids with Seaver's, I just say you can play through. You should rest so it feels better, but relative rest, meaning maybe they, instead of in basketball practice doing killers up and down the court, they are going to work on their shot and they save it for the game so that they go in and run hard during the game, but they're not running as much in practice. Or maybe during a tournament weekend, they're not playing as many games or as many minutes, right? Whereas if there's a stress reaction, we need to shut them down, put them in a boot, and let that heal. The other thing that sometimes gets misdiagnosed with Seaver's disease are dancers or gymnasts that have posterior ankle impingement. And so oftentimes they will have a really prominent posterior part of their talus that when they get up into plantar flexion, especially those dancers on point, they'll start to bump and then get some edema within the posterior aspect of the talus, or sometimes that secondary os trigonum, a secondary bone back there. So that's also another diagnostic consideration when you're thinking about Seaver's. Does anybody know what this one is? In the foot. So it's Easelin's, fifth metatarsal apophysitis. And the thing about growth plates and apophyses is they can look really weird on x-ray. So that may be normal. I think it looks a little widened, right? A little further away than it should be. But this oftentimes you see around the same age, maybe 10 to 12, and it's where that perineal brevis attaches onto the base of the fifth metatarsal and pulls. So you're going to see this in soccer players who are doing a lot of pivoting cutting motions. And they'll be tender right there. Oftentimes you don't need x-rays. However, the differential can be stress reaction, stress fracture in that bone. So if they're tender right along the base of it, then that can be more consistent with an apophysitis. If they're older and that apophysis has sealed back in and fused together, then they can just have an avulsion fracture there or have an avulsion fracture of the apophysis. But in older kids, you're going to worry more about actual fracture. Jones fractures are going to be here. We worry about those because they don't have a great blood supply and oftentimes need a surgery to fix, even if it doesn't look displaced. And then higher up in the metatarsal shaft, you'll get more problems with stress fractures. But with all of these, the treatment is the same. Rest, modifying activities, and sometimes putting in an orthotic or shutting it down and putting them in a cam boot can help if they're really sore just with when they're walking. So here's a kid I saw with soccer players, started getting gradual pain in the base of the fifth metatarsal, and then one day kind of turned funny on it and then felt more pain and swelling over the base of the fifth. And I got these x-rays, and you can see how that just looks a little more inferiorly displaced. And you'll see that on the AP view, and then on the oblique view, you can see how it's kind of hanging on there. But that's okay. That's gonna heal back. And honestly, even if it doesn't, the tendon scars down, and they do fine. And rarely does this ever need any surgical intervention. If it's really displaced, then we should have somebody look at it. But this athlete did really well. All right, moving on up the kinetic chain. So the knee, Osgood Schlatter, right? And you will see this all the time. And we're taught that usually it's benign and it's no big deal. But I've seen some cases where it can be more of a problem, and we'll talk about that in a second. But basically, where the patellar tendon attaches onto the tibial tuberosity, there's an apophysis there, you get that overuse traction, and then some fragmentation of the tibial tuberosity that causes pain. You'll see that swollen, painful bump. You do not need x-rays to diagnose it. It's a clinical diagnosis. Again, the management's going to be the same, rest, modifying activities. I do think that for all of these, there's a role for proximal strengthening up the chain, because if they're overusing their patellar tendon, it's telling me that they're not engaging through their core muscles like they should, and they're overloading that. So working on strengthening upstream is important. Sometimes you can use an infrapatellar strap. I tell kids it's 50-50. If you find that it's helpful, great. If it's not, then don't use it. I think the idea is that it just offloads the tendon a little bit so that it's not pulling as much. And then usually we're taught that this goes away once the growth plates go away. But there are times when it doesn't, and times when it can be more of a problem. And there's some new literature looking at what really is going on. Is this an apophysitis, or is this a tendinopathy, or is it a little bit of both? And it's all connected, so it probably is a little bit of both. But if you look at an ultrasound with Doppler on a normal tendon and tibial tuberosity on an unaffected knee, that has that characteristic. It looks pretty normal. On the affected knee, you can see the fragments of bone in here, the tendon gets thickened and disrupted, and then it actually has abnormal blood flow. So there's these neovascularity that develops within these tendons at the site of that apophysis as well. So it's a spectrum probably, but interesting nonetheless. And then sometimes what can happen is that you get what we call this Osgood Pearl. So this girl was 10 years old and the best karate athlete in the region. And I'll tell you, I see a lot of the best athletes in the region, a lot of them on the same time, the same day, which makes, you know what I mean? Like the one mom says, my kid's the best baseball pitcher in the States, and then the next patient, that's so, right? Anyway, she was the best in the region at age 10, and she knew she had Osgood Schlatter. She had been dealing with it, still having symptoms, continued to play through it, and then one day did a little kick or something, and in her right knee had much more pain than she normally had, and a lot of swelling right around that tibial tuberosity. So on her left unaffected knee, you can see a little fragmentation here, and what may not project very well is there is a little fragmentation right there, but look how different it looks over here. See that little spot right there? And I'm sure it doesn't project, but right here, there's actually a little avulsion fracture from the tip of that. So that's been going on for a long time. It's smooth and round, but up here a little bit, it's hard to see from here. There was a fracture. So you get an MRI, and she's got some swelling around through there, and as that tendon has been pulled away from there. So she ended up having a procedure where she had a screw placed back in there because it's considered more of an intra-articular problem and needed to be tacked down. Unfortunately, she had a lot of problems with this and ended up having intractable pain, had the screw removed and replaced, then developed osteomyelitis, and then now has a chronic regional pain syndrome. So first, do no harm, right? Probably we could have gotten by with saying, I know you're the best karate athlete in the region, but we need to put your knee in a neomobilizer for a little while and shut things down. And if that doesn't help, then we can do a surgery, right? So there's problems with it. Then the other thing is that let's say you've got an 18-year-old that is still having pain over the tibial tuberosity. That's not normal. They probably have an unstable little fragment here, and that can easily just be excised if it's still problematic. But usually it goes away once they reach skeletal maturity. For all of these things, I usually tell kids that it's about a 2-year process. So once they have heel pain with Sievers or knee pain with Osgood Schlatter, they'll have some problems that'll be up and down for 2 years depending on the sport and what they're doing, and then it goes away. So I'm more careful telling patients to play through pain, and normally I don't tell anybody to play through pain, but with apophysitis issues, and especially at the knee, I tell them about these stories, that sometimes you can make it worse, and you shouldn't just be playing through pain all the time. Okay. Up a little higher, along that patellar tendon, at the proximal pole is where you get Sinning-Larsen-Johansson. So there's an apophysis at the distal pole of the patella there, and kids can have problems with that as well. Those tend to take longer, and they just hurt more for some reason. What you want to make sure that is not have happened though is that has fractured away, or you have a patellar sleeve fracture. So I had one kid that we knew he had this. He rehabbed, did really well, and then was playing lacrosse and was running and felt immediate pain, and he pulled off where the patellar tendon attaches on to the patella and had a patellar sleeve fracture, meaning that just the whole part of that bone comes off, and that's a surgical issue, usually. Okay, moving on up to the pelvis. The most common place you're going to see apophyseal injuries, apophysitis or avulsion fractures, is at the ischial tuberosity where the hamstrings attach. So this was she was 12 years old. She was a soccer player and a dancer, ballerina, really inflexible though. And so her dance coaches would always say, you need to stretch, stretch, stretch. You need to do more stretching. So there's a controversy about, do we really need to stretch or not? And people will say you have to stretch to prevent injury. That's probably not true. There is a balance that needs to occur, and a lot of these kids are going to have really tight hamstrings, and that's probably getting them out of balance. But if you're a dancer and you're constantly stretching on your hamstrings and you've got open apophyses still, and by the way, the pelvic apophyses stay open until your early 20s, then what you're doing is you're constantly pulling and pulling and pulling on that apophysis and setting yourself up for a problem with apophysitis, right? So she had some achy posterior buttock pain for a while, and then was playing soccer, went to kick a ball, and felt a pop. And so you can, I don't know if you can see that very well, but she pulled off her whole apophysis right there. So on her right side, looks a little bit more normal, where you can see that dark line coming through, and there she pulled that off. I only worry about these if they're more than 2 centimeters displaced. Sometimes they do need to be tacked back, but kids do remarkably well by leaving that alone. And then the hamstring tends to just scar down. They may have a little residual strength deficit, and sometimes they have problems just sitting. And in that case, then you can go do a surgery later. But if it's not more than 2 centimeters displaced, I leave them and I let them heal, and then we do a ton of physical therapy, and they do really well. And she did great. This is actually a daughter of a pediatrician in the community. So other examples of apophyseal avulsion fractures. Here's an ASIS, apophyseal avulsion fracture, lesser trochanter. So this is where the sartorius attaches. This is where the the hip flexor iliopsoas attaches. So this kid, he was 13, and his main sport was wrestling, but he did cross country in the fall. And he started having some anterior hip pain, kind of achy stuff, and then was doing a sprint, like a pickup workout, and felt an immediate pop and pull and had some swelling over the anterior hip. And it's really subtle on here, but see over here how it just looks a little more irregular over here. It's very subtle, but that's where he was tender, right there to touch. Had a hard time lifting up his leg. These are the lateral views, which here is that normal side. That contour is a little more smooth and round, and here it's jagged. And what you don't really appreciate on those x-rays is how actually far of an avulsion fracture it is. I think it measured like 1.5 centimeters or something. So sometimes the x-rays don't show everything, right? But he rehabbed really well. Didn't do anything about it. Okay, moving on upstream. How are we doing on time? Okay, so Little League elbow, you're going to see this a lot as well. So medial epicondyle apophysitis. And usually you're going to see it in ages 10 to 14. And when you see these kids, usually they're pitchers, but not always. Sometimes they're just been throwing hard from the outfield. A lot of times you're going to see them come in right after tryouts in the spring. This is when this starts to ramp up. There's seasonality to medicine, right? You see strep and influenza, and then you've got well visits, and in sports medicine, the same thing, just depending on which sport you're playing. So I'm going to start to see these here pretty soon. And if there's not a lot of significant tenderness and swelling, and I didn't feel a pop or anything like that, I don't necessarily get x-rays. But if there is, then I do. And the problem with just x-rays is that sometimes you don't really understand how much of displacement there is, and you need several views of the x-rays to look at it. So both an AP, a lateral, but an oblique view too can give you a better look to see, is it anteriorly displaced at all? But this kid came in, did feel a pop, and you can see he's probably just a little displaced, maybe, not too bad. But we let that heal, and 2 months later, you can see how it's really scarred down in good alignment, extra bone formation, periosteal reaction up through here, and he did great. But if there's more than 5 millimeters displacement, then those should be fixed with a screw. And we'll splint them in a long arm splint for a few weeks, and then start to work on range of motion. And then the most important thing is that we talk to these kids about why this happened. And we talk to them about the importance of pitch count, pitch type. So they need to be monitoring pitch counts, and a lot of them have no idea even what that means, and their parent will say, yeah, but the coach he only has them in like 3 innings, but they're playing on 2 teams. So who's watching this, right? So it needs to be the athlete's responsibility, the parent's responsibility, it needs to be all of our responsibility. And pitch type, so we try not to have these kids throw curveballs before the age of 14 or when they're shaving, because that tends to put a little more force across the elbow. Now that's a little controversial. There's been some studies that show that there's more force across the elbow with a fastball rather than a curveball, but we're still recommending that stay with a fastball to begin with, get your velocity or get your control and accuracy down first before you start working on velocity. Okay, so this was a case that actually looked great, right? But his exam was so concerning that I was like, there's no way that something didn't happen there. And maybe it's his UCL, maybe the ulnar collateral ligament pulled off in this kid too. And so ended up getting a 3D CT, and look how far off he is, right? So sometimes it can be really confusing. All right. So we talked about this a little bit, pitch count, pitch type. A lot of times it's mechanical flaws. When these kids come in for their physical, or for their sports physicals, if they're an overhead athlete, you should really try and do a good assessment of their rotator cuff strength and look at how their scapula move. Have them take their shirt off and have them lift up their arms up and down and watch their scapula. Because most of these kids, they're going to have some really abnormal, wonky scapular mechanics, and you want to make sure that you address that before they start throwing, because otherwise they're going to start to get some things down the chain, whether it's Little League shoulder or Little League elbow. So watch for that. They should not pitch if they're tired, because their mechanics are going to break down. And they shouldn't pitch with a radar gun. Showcase participation is not recommended. Okay, one final thing up in the shoulder. One of the things that I've been seeing more and more of is acromial apophysitis. And I see it in dancers doing kick line, where their arms are always up like that. And then the other thing I see it is in kids that do a lot of hunting, or this new sport like trap shooting that they're doing, or skeet shooting in high schools. And from the kickback of the gun, just constantly putting pressure on that apophysis, and then it gets irritated. This is an axillary view of the acromion and the clavicle and the acromion and the apophysis right here. And then you can see all the marrow edema within it, and up here as well, marrow edema within the apophysis there. And then one final plug, because Dr. Vey and I share a lot of patients, and sometimes it's hard to figure out, is this apophysitis or is this enthesitis? So I see a lot of kids that have juvenile idiopathic arthritis, let's say, enthesitis type, and they're also athletes. And so we have to figure out, are they tender here because it's an overuse apophysitis, or is this just a flare-up of their disease? And sometimes that's hard to sort out. But usually what I ask them is, how is the rest of you feeling? Because if the rest of you is flared up, then it's probably your enthesitis. If it's just this, and you've been really playing, you're active in your sport, then it's probably apophysitis. Okay, so what can we do to prevent this all from happening? One of the most important things is that they come in conditioned, ready to play, and that they do a dynamic warm-up, not static stretching to begin, but get the muscles warmed up, the blood flowing to them so that they're not super tight and pulling on those apophyses. Work on core strength. Look at the biomechanics, because there's none of us move right, and especially our kids. We really should be addressing this in the grade schools and having them do some functional injury movement things, or functional movement to prevent injury. And then trying to avoid overuse, which is easier said than done. So what can we do as pediatricians, as parents, as coaches, some of you maybe? We've got to be a good positive role model and dispel all those myths that you should play through pain, no gain. Let's start them early, right? Specialize early. You're going to get behind if you don't. And then I think we have to just completely unstructure play. Get these kids back outside. Let them make the rules. Why do we as parents always think that we need to be telling them how to hold their bat and how to do this and that, and having the conversation in the back seat after a game about what they did wrong? And then as pediatricians, really providing that anticipatory guidance at their well visits, or any time that you see them, or if you see them for injury, and talking about the risk of injury and overuse. So get them outside, and if you focus on these three things, the 3 Fs, as I say: fun, fitness, and friends, playing in the backyard, nobody's making up the rules, they're just having a good time, they're getting the benefit of playing a sport together and just being kids. So I think that's where we have to come back to. So we have a program at TRIA, through our TRIA Kids program, where we go out into the community and do some different talks about all sorts of things, whether it's concussion or overuse injuries, heat illness, hydration. We've been go to the state fair, out to the soccer club in Blaine. We were at the MLB Legends Clinic a few years ago. We go to the safety clinics. Several of the communities have safety clinics for fourth graders where they learn all sorts of different safety things, and sports injury prevention is one of them. And then the other plug that I wanted to talk about is the Positive Coaching Alliance. So I'm on the board of the Positive Coaching Alliance here in Minnesota, and it's a national organization, but focusing on making better kids, better athletes through positive coaching. It's not taking the grit out of sport, but it's teaching coaches and parents and the athletes how to continue to make sport a positive experience. And it's one of the most amazing organizations. They put on workshops for parents, coaches, and athletes, and they are all inspiring. And even if you're a seasoned coach, you learn things from it. So it's pretty cool. And I think that's it. So, any questions at all? How are you, by the way?
I was interested in the 50% overuse that you showed in one of the first slides and so forth. Can you break that down by age, by type of sport, and by age? Is that a fair question?
Yeah, you can. And Dawn Comstock at in Ohio, right? At where is she? She's an epidemiologist that has what's called high school Rio, reporting injury online. And so she has this huge database of participating states where they track all of this. And so you can break it down by sport, by injury. So like concussion, for example, you can look at which sport has the highest rate of concussion, and with overuse injuries as well. And so it tends to be the more endurance type sports. So soccer, lacrosse, gymnastics, dance, that you get the overuse injuries.
Cross country?
Mm-hmm.
Swim? What about swimming?
So swimming is shoulders. Swimming, and these kids come in, and this is a typical swimmer that will come in, maybe 14, 15 years old, come into my office like this. This is how they're sitting, right? And they're super depressed, like crying almost because their shoulders hurt. And you have them try and move their shoulder, and they have the most abnormal mechanics you've ever seen. And a lot of times they'll do this like, they'll say my shoulder's popping out of joint, and they certainly may have some hypermobility where they're subluxing, but they'll do these like weird things because they have just had these abnormal mechanics develop, and then it becomes a pain issue, and their neuromuscular recruitment gets all screwed up. So swimmers and shoulders are a problem. Hi, Joe.
So are genetics a role? Do genetics have an obvious role in any of this? If there's a family history or parents that have had these injuries, are kids more likely to get them? Any idea on that?
Yeah, so with like Osgood Schlatter and Sievers, usually there'll be a sibling that not always, but oftentimes, they'll say, oh yeah, my older brother had that, and they knew about it already. That's what they figured it was. I had a 6-year-old come in to see me yesterday. She does gymnastics 10 hours a week. So now there's no, there was a study that recently came out in Pediatrics, I think you guys might have read it, that said that when they looked at the risk of overuse injuries, if you participated more hours than years you were old a week, so for her 6 years old, 6 hours a week is probably all she should really be doing, then you were more prone to overuse injuries. So she's doing 10 hours of gymnastics. She's 6. She's doing like right off back handstrings. I mean, she's great. She's really competitive. She obviously has natural talent. But she had heel pain, and her older brother had Sievers, kind of at the same, like right now. And 6 is probably too young to have Sievers. Now, it may be, but she had more anterior calcaneal heel pain, and so I'm treating her as a stress reaction. So you will see it in families, or you'll look at dad's knees, and dad has a big old knob on his knee from his tibial tuberosity. So
follow up on that, there are some advantages to hypermobility, for example, or other traits. Do you end up identifying a fair number of individuals that need to go to genetics?
Yeah. So, and as you said, hypermobility is going to select out, and for sports like dance, gymnastics, where they need to be more mobile. The problem is that it's hard on your joints, and those of us with hypermobility have more problems with joints. And then there are some that really are very mobile, and you're thinking Ehlers-Danlos, and there's definitely a few. I think there's so many undiagnosed variants, just sort of low-level variants of Ehlers-Danlos out there, or some kind of collagen vascular issue.
Because this has come up, I think, in basketball in particular. Some of these phenomenal high school athletes, you look at their wingspans and...
Yeah, so for Marfan, and absolutely, and that should, I mean, that's one of the things on the Minnesota pre-participation physical exam is right on there looking for Marfan stigmata. And yeah, you got to screen for that.
Just another question that just dawned on me. In patients with acute sports injury with the edema and so forth that you see, do their SED rates or C-reactive proteins rise at all? Do you know?
Probably not. I think it's really more of a localized inflammatory response. I don't know that that's ever been looked at. I've never seen anything like that. It's an interesting... I don't think it would be enough to really move the dial on those numbers, though.
Rich?
If you had a hemarthrosis, your SED rate will go up. But I don't think for an acute tendon injury or Osgood Pearl it would go up. It's a question that sort of indirectly comes up in our clinic as to what's sports and what's inflammatory. So we end up having to do lab work sometimes because there's a family history and they're worried about arthritis in the family. But if they get hemarthrosis, that drives your SED rate up.
Yeah.
Interesting talk, thanks. Just curious about nutrition and its impact on some of these injuries, both, like vitamin D, calcium, as well as, obesity on the other spectrum, anorexia, and if those pieces play a factor.
Yeah, absolutely, a huge role. And I mean, on one end of the spectrum, you've got concerns for female athlete triad, where you've got inadequate caloric intake that then, whether that's intentional or not, sometimes there are college athletes that just aren't ready for that level of intensity plus all their schoolwork. They just don't have time to eat as much as they need to. Or it can be intentional and in an all-out eating disorder. Inadequate caloric intake causing problems with menstrual cycles, so they're either irregular or completely amenorrheic, which then affects bone health, right? And so then there's the vitamin D, and up here we are all vitamin D deficient probably, and kids don't get enough calcium anyway, so there's that playing a role in bone health. I think it depends on the kid, and when I was a general pediatrician, parents would come in all the time and say, my kid doesn't, he only eats white food, right? This is my son, by the way. Drives me crazy. And I would just say, don't worry, they'll get what they need. Don't push it. But I don't know. I think that it is important what you put in your body, and athletes need more protein. So most of us need 0.9 to 1 grams per kilo per day, and athletes are turning that over more, so they need probably 1.2. Athletes probably need a little more iron. So there's this whole concept of foot strike anemia in our endurance athletes, and the other thing that drives pediatricians crazy is when the coaches have their athletes go in and say, I want to get a ferritin level, and we always used to cringe at that. But I've seen so many, they're low, and I like their vitamin D and their ferritin to be above 30. They perform better when they're up that high, and there's been studies that show that they feel better, they perform better, and it's an easy thing to check. It's a cost, but If there's concern and it's an endurance athlete, then I do it. And especially if they're having problems with fatigue, then I'll do it. And then you've got the whole other side of supplements and creatine. And I'm okay with a protein shake, but none of the other stuff. You need to get it from your diet.
For parents of athletes, I think the most dreaded word is rest. So I'm just curious, what is your compliance rate with rest for these families?
Depends on the kid, depends on the parents. There's some times where we will all work with them. They have one more basketball tournament, and I say, you're not going to do any permanent damage. You're going to prolong your recovery, but go play. And if pain doesn't let you play, then stop and come out. But try and get through it. Now, there's other things where they shouldn't. If it's a femoral neck stress fracture or something like that, we need to have a rest. But it's, for the most part, they end up, the other thing I'll tell them is that you may not play like you want to play. And they get that. And then they realize that, all right, yeah, I'm not going to, this may be not worth it. Or maybe they're playing basketball, but their main sport is baseball. So we'll say, well, do you want to be ready for tryouts? Or do you want to finish up this tournament? What's more important?
Thank you. When you're talking about rehabbing the patients, do you find it important to send them to certain physical therapists or pediatric physical therapists? Or is it okay to just say, go to your local rehab facility?
I think it matters who they see. But I think what matters more is that they buy into it. So I think that you need to know who your physical therapists are and have a good relationship with them and know that it's somebody that takes care of sports-related injuries. I don't think it needs to be a pediatric-specific physical therapist necessarily. Sometimes it should be. Sometimes it needs to be somebody that's really good with hypermobility, for example, or that knows how to manage a swimmer's shoulders. So when you tell the patient, I'm going to have you go to physical therapy, the problem is that that's work. That's work for them, and they have to be compliant with it. So there's not a magic bullet. It's just that they've got to do the exercises. And when they're young, that's really hard because they've got all these other things, all these activities that they're going to, plus school, plus they're 11 years old, and they don't even make their bed every day. How are you going to get them to do these exercises? But if you say, here's who you need to see. You need to go see Michelle at this place. She's really good with this, and this is why. Then they buy into it, and it makes a huge difference. Physical therapy does, even with the younger kids. And people will say, well, they don't gain muscle hypertrophy at this age, so why send them to do strengthening? Well, they gain it through neuromuscular re-education and neuromuscular recruitment, which in my mind is more important than anything. You can do all the core conditioning in the world, but until your brain actually recruits those muscles as you're moving, it's not doing anything. So that's where the PT comes into play to get all of that functional again. The other really interesting thing to look into, if you ever have time, are the roots of sports specialization, dating back to 70s and 80s during the Olympics and the Eastern, like the Russian experience, Nadia Comaneci in gymnastics, and we as Americans looking at that, saying, wait a minute, how do we get to be that good? Well, you practice all year long, and that kind of started it. But even it looks at chess players and musicians and artists and looking to see how they got good at their craft. Well, it's practice, that deliberate practice. And then you come in with Erickson and then early 90s who really came up with the concept of the 10,000 hour rule made popular by Malcolm Gladwell. If you read that book, Outliers, it's a good one. And that you have to do something 10,000 hours to become proficient at it. So then why not do that for these kids? The problem is that when you are developing proficiency at something, you go through these phases. And the first phase is the romance phase, where you start to fall in love with it and start to really enjoy it. And then you start to do the work to become better, and then finally you become proficient. And what's happened is we've sort of completely jumped ahead. We've missed the romance phase, and now we're just doing this early professionalization of these kids, and then they don't love it. And if they don't love it, how are they going to have the motivation to do the deliberate practice to get better? Thank you.
You have been